worked. All right. So if you have any questions, just drop them in the chat on Facebook or in the comments or something. Erica is looking over those, and we'll try to answer them as they come in, or we'll wait till the end, actually. All right. So like I said, my name is Dr. Scott Jahn. I'm a chiropractor. I have a clinic in Cebu in the Philippines. Been practicing since 2005. Before that, I was a personal trainer at Equinox Fitness Club in New York City. Long background of helping people. Been on a lot of mission trips, been to Haiti, a lot of stuff in the Philippines. And so that's a little bit about my background. So today, what are we going to cover? We're going to cover the TMJ, right? TMJ stands for temporomandibular joint, right? So we're going to talk about a little bit about the anatomy. So we're going to go through the anatomy a little bit quick because my job is not to make you guys doctors. What my job is to do is to use this as a reference tool. So we'll go over it quick. It's being recorded. It's going to be put on YouTube. So if you go back and say, okay, well, I got to work a certain muscle. I want to learn or understand why my cranials are doing this or why my cervicals are doing this, right? You can kind of go back and look it over and say, okay, now I see where the attachment is to that muscle, yada, yada. All right. So don't be worried if we go too fast, you don't get everything because it's not really necessary for what we're going to do. Okay, then we're going to understand the causes. Okay, we're going to go over a bunch of different causes, not only where we feel the pain that the problem is. We'll talk about how to restore it. We'll discuss a little bit about lifestyle and controlling inflammation. And then we'll put together a little plan for you. All right. So let's get started. We're going to start with the anatomy. All right. Temporomandibular joint is right here. Again, temporal bone, mandibular, mandible. Right. And then this guy is called the condyle. So this condyle fits in this fossa. Oh, I'm sorry. Fits in this fossa on the temporal bone, right? And that's your temporomandibular joint. Okay. So we're going to go over some other stuff as we talk about attachments of muscles and stuff. But again, just so that you've got an idea of where things are in relation to other things and why things can rub on other stuff and whatnot. All right. So we'll start with the ligaments that hold the joint together. Right. You have these two ligaments in the back right here. They connect from the skull to the mandible. This one connects from the sphenoid. Sphenoid is like the central bone of all the bones in the skull connect to the sphenoid, which we'll discuss a little bit more later on. And then over here, we have the styloid process, right? So this is a stylomandibular ligament. This connects to connects to that temporal bone, okay? And of course, on the joint itself, there is a capsule right here, right? Which is just enclosed and inside is some fluid, right? So called synovial fluid, which we'll discuss in a minute. And then there's some ligaments that reinforce the capsule. And then one other very important ligament is called the pinto ligament. We can see it over here. What that connects to is connects the condyle of the jaw to a little tiny bone in your ear called the malleus. This is why when you're up on an airplane and you open your jaw real wide, you pop your ears because that ligament is pulling on one of the bones in your ear and it relieves the pressure, right? Abracadabra. Now you know. So if there's something wrong with that, it can cause things like tinnitus, right? That ringing in the ears or something of that nature, all because that little ligament is acting up. Okay, if we open up that disc, what do we see inside? Well, there is called a biconcave disc right here. It's biconcave because it follows the shape of the joint, right? There's the fossa from the temporal bone right here. We can see it's a very thin layer of bone. So, right, it's very prone to injury, right? If we have like a fall on the jaw or something like that, I keep doing that. It can cause a problem. It can fracture here, which could be life-threatening, right? And the disc has space below, space above. So as that jaw moves, we'll talk about how the disc moves with it and what these muscles do while we're moving that joint. Back here, we can see there's an ear canal. So, right, that'll play into things when you talk about, oh, well, if you had an ear infection, right, it can affect your TMJ or vice versa or whatnot. So it's supposed to be a video here showing the normal movement. Oh, there we go. All right. So here's the normal motion of the joint, right? Here's the condyle, and it'll rotate forward. It'll rotate, and then it'll translate forward. All right, let's see if we can see it one more time. So we'll see it rotating. It rotates, and then it translates forward, and the disc goes forward as it translates. Right? So if we go back here, you see here's our disc, right? So this muscle right here, which is called the pterygoid, it's a lateral pterygoid, the superior muscle of the lateral pterygoid. Here's the inferior head. So this muscle has to function properly in order to get this disc to stay in line with this joint, right? It has to almost release because, so when this joint rotates in the beginning, right, the disc has to stay underneath it, because if it doesn't back up, or if this doesn't stay with the rotating of the joint, right, it'll slip off and we'll get a clicking noise. And then afterwards, it'll translate forward, which is from another ligament. All right. Oh. Second. Next. There we go. So muscles of the TMJ, right? We're going to talk about a couple of them. The opening muscles are going to be the temporalis, the masseter, medial pterygoid, and the superior head of the lateral pterygoid. Pterygoid is, I think, a Latin word for wing. It's the wing of the joint. It's right in here, right? It looks like a wing of the sphenoid bone. The sphenoid bone is part of the temple right here. Is the wing of it. And then, whoops, sorry. And then it has like these two little wings that come out here where these muscles attach. So they're called pterygoid, for wing-like, I believe it's called. It's the origin is. All right, and then muscles for opening, right? It's a little bit more difficult because of the angle. But we have the inferior head of the lateral pterygoid. You'll see there's a double-bellied muscle called a digastric, then a mylohyoid and a geniohyoid, and some scalenes or something like that we'll talk about. All right, so origin of lateral pterygoid, right? Remember, the top half is connected to the disc, which means it has to allow that disc to translate as we're opening that joint, that TMJ, right? So it's going to connect to that joint into the capsule, and then and then the origin is going to be on the sphenoid as well. Right? Both heads, the origin is from the sphenoid, and then connect to that capsule. Okay, all the nerves is going to be the same for the muscle mastication, which is the fifth cranial nerve, right? For the trigeminal nerve. So there's a couple muscles that'll have some other innervations, but for the most part, that's the nerve we're talking about. All right. Next is the medial pterygoid, right? It's located on the origin of the medial surface of the pterygoid plate, right, on that sphenoid bone, also on your maxilla and your palatine bone, and it inserts on your jaw. It'll elevate, okay, along with the masseter and the temporalis, which we'll see in a moment. And it's innervated by, again, fifth cranial. There's our temporalis, that big fan muscle on the side of our head, right, located in that fossa. The insertion of this muscle is on the front part of the jaw, called coronoid process. This can cause snapping too. This tendon that's connected that muscle to the front part of that jaw. That, if it's tight, can sometimes cause a snapping and can be confused with the disc in the actual TMJ. Right. It elevates along those other couple muscles we mentioned. And last one for that one is the masseter, which is right here, which per square inch is the strongest muscle in the body, right? So very strong muscle, a lot of receptors in there, right? What happens is it has to give a feedback to the brain, otherwise it'll keep kind of contracting and crack your teeth open, right? So you have to have receptors in there to tell the muscle when to turn on and turn off, depending on pressure and speed and things like that, right? So we'll see later that can get dysfunctional and have to be corrected. All right. After that, we have our accessory muscles, right? There's just there's two of the main ones, which is again that double belly muscle we mentioned before, which goes from here, goes from your jaw, the front part of the jaw. It'll attach to a bone called your hyoid, which is in your throat. The hyoid bone is the only bone that doesn't attach bone to bone, attaches bone to only muscle. That's the only one. And then it'll swing back around and attach to the posterior section of your temporal bone, right? The unique thing about this Digraphic it actually is innervated by two different cranial nerves. Cranial nerves mean the nerves come directly from the brain. So the front part is cranial nerve 5, just like the other muscle domestication we talked about. But the back is cranial nerve 7. So right, if somebody has something like a facial paralysis or something like that, that could be affected cranial nerve 7, which can affect a portion of that digastric and consequently the TMJ. All right. So one thing they all have in common, right? They all have referred pain to TMJ, right? Referred pain being from trigger points. Remember, we talked about we have muscle spindles in the bellies of muscles, right? That tell the muscle, tells the brain information about what the muscle is doing, right? Those can get taught, those can get misinformation, right? And we get what's called trigger points, right? We get little taut bands that'll cause the muscle to either contract, inappropriately or something of that nature. And then we can get the jaw is going to be out of alignment, or we'll get, things like what's called bruxism, like grinding your teeth at night or something like that, because these muscles get bad information going to the brain. So they all go to TMJ and other areas as well. Same thing with our stabilizer muscles, being the digastric and the mylohyoid. Also the scalenes, right? Our scalene muscles, they attach to the front or the cervical spine at the transverse process and the first two ribs on the chest. So they have a lot to do with breathing, right? So if we're a shallow breather, right, the scalenes can get tight and cause problems, right, from that whole chain. Nerve supply, as we mentioned before, is the trigeminal nerve, right? That's cranial nerve 5, right? There's 3 branches of it. So the other 2 branches are sensory, which is ophthalmic, right? The upper part of the face, and the maxillary, right? But the lower part, the mandibular, has a sensory and a motor portion, which is we mentioned before, all those muscles of mastication. All right. So the interesting thing about our TMJ is that trigeminal nucleus, it actually, when it goes back into the brain, it will descend down the brain stem and it'll attach back in at around C2, C3, right? So you can get a lot of problems where you have a C2, C3 subluxation or other nerves that go to the C2, C3, like the suboccipital muscles, the muscles right behind our head, right? So if we're looking at like a computer all day long, right? Our head is in a little bit of extension. Those suboccipital muscles get tight, get spasmy. The nerves going to those being at the same root as that trigeminal nerve, and it'll make the trigeminal nerve sensitive to things like what's called nociception, right? Our pain response. All because the volume is set, too sensitively because of other feedback, right? So that's a very important area where if we're going to correct our TMJ, we have to look at our cervicals as well, right? The vascular supply, the only thing you really need to know there is it's coming up from the carotid artery, right? So when we get into TMD, right? TMD just stands for temporomandibular joint dysfunction, right? Just add a dysfunction to the end of that, right? A few basic facts. It was first identified in 1934. Back then, it was just thought of as a dental problem, right? Thought maybe as the occlusions of the teeth will get misaligned and cause stress on the joint and whatnot. It's gone through quite a evolution since then, which I'm going to show you on the next slide in just 1 second. But the prevalence, about 12% of the population will suffer some form of temporomandibular joint dysfunction. It may not always be in the joint. It may be, like if we look on the right side, headaches, could be right problems with the face, ear, neck, right, things like that. For some reason, women get it twice as much as men. Average age is around 30 years old, and only about 30, maybe 40% will report some clicking in the jaw, right, which could be a disc, but it could be something else as well, as we mentioned before. It could be like a tendon from the temporalis muscle or something like that. All right, so you can get pain, like I said, jaw, face, ear, neck, right? You get grinding, clicking if we get degenerative disease in the joint itself. You get popping sounds from various things, right? Like ankylosing of the capsule if it becomes fibrous, or a tendon or something like that. Difficulty chewing or opening your mouth, right? Headaches, lockjaw, and abnormal mandibular gait. Mandibular gait being how you open and close your mouth. So this is kind of the evolution of where TMJ issues have gone, right? It's a whole lot of complicated stuff, but we're gonna say, like, from a functional standpoint, we're gonna look at just two categories. We're gonna just kind of keep this simple, right? Category one is everything to do with that capsule that I showed you in the beginning, right? All that stuff in there, which is right there on the left, that tell you, right, you can get capsulitis. Anytime you see itis, think inflammation. So capsulitis is inflammation of that capsule. You can get a disc problem, right, in the middle before where I showed you that disc, which will show you, right, what's going on with the disc. You can get synovitis, right, the lubricant that nourishes that joint that sits in that capsule can get inflamed. And then degeneration, right? Degeneration just, every time you see degeneration, it just means that you've had dysfunction for quite some time and your body has been wearing down at an accelerated rate. Right? That's degeneration, right? So we get that one right out of the way. But let's look at the inflammation part of it, right? So again, we have two things: either have synovitis or capsulitis. Capsulitis, the capsule gets inflamed and it gets very fibrous, right? So it loses its elasticity. So you'll get like stiffness at end range, things like that with a capsulitis. If that capsulitis is chronic, it can start ankylosing. It can start getting turn into like bone, and it'll attach to actually this front part right here, which is called the articular eminence. It's a little bump on this bone called the zygomatic bone. And this bump is kind of important because it'll dictate how that jaw opens and how it'll track, right? Everyone's can have shape be a little bit different because of your anatomy, but that's the bone that'll determine like where it stops, or you get a click or something like that if we have an abnormality or something. All right. So capsulitis, again, you get a rubbery end feel, right? You lose the elasticity of the capsule. But a synovitis means inside the joint, right? You can see under this disc and over this disc, right, is synovial fluid. That fluid is meant to keep the joint healthy, right? Brings white cells to that joint. It brings nourishment to that joint, right? And if that synovial fluid gets interrupted because the membrane is inflamed, right, it can cause problems. It'll inflame and you'll get more pain on like biting, right? Because the whole capsule is like blown up. So any kind of pressure on that joint, not so much on the stretch, but on that like a bite or something like that, you feel that pain, is probably that synovitis. All right. So we'll talk more about how to deal with chronic inflammation. Inflammation is good, but chronic inflammation is not good. So we'll discuss a little bit towards the end of the lecture about that. Okay. All right. Let's go on to that disc popping. All right. It's probably everyone's favorite part. The disc pop, pop, pop. So the disc is supposed to move as the joint moves, as we said, right? The joint first, from about, depending on size of your anatomy, about 20 to 30 millimeters of opening is a rotation on that joint right there, right? After about 30, right, again, the 20 to 30 millimeters opening, then we get a forward translation. And we get that forward translation, that's where the disc has to travel with the joint, right? And if it either doesn't clear, you'll see a pop noise, right? I'll show you right here. We have what's called width reduction, which means that the joint gets a little pop and the disc falls back into place, and without reduction, which means we don't get clearance, so we get almost like a locked jaw. So let's look at the width reduction first. So here's the joint, it's going down, right? Here's the disc, and there, boom, you see it pop back. Right? So it looks like the ligament is too laxed in the back, right? It's down here. As we translate forward, it'll pop back in, right? And that's that pop you see. Then without reduction, we can get, right? It'll just stay in the front and we'll get it jamming up, right? Sometimes that can be fixed, right? If it's something from like lateral pterygoid, but right, it's the joint doesn't have blood supply, so it's very difficult to try and repair, for the joint to repair itself if it's coming from the posterior ligament or something like that. But we have to look at our structural alignment when we're talking about our TMJ, because if we saw degeneration being one of the primary causes of a TMD, it comes partially, at least, from the cervical spine, right? That we talked about, that upper cervical spine putting you into a hypervigilant state from that TMJ because of the common neurological input. But additionally, as that head migrates forward, right, we get that extension in the upper cervicals, we're going to get a shift in our, there we go, a shift in our jaw, right? The jaw comes back and up and actually kind of jams in that posterior area of the joint, right? And that posterior area has a lot of vessels in it, and it also has the nerve endings in it as well. So, right, we have to straighten that up if we're going to have any chance of easing the stress off of this joint and allowing it to heal properly. Additionally, if we look at our dermatomes of C2 and C3, where the nerves come out that go to different areas of the body, right? You'll see they both just wrap right around that TMJ. So you couldn't have a phantom TMJ pain just because you have a subluxation at your upper cervical and your C2 and your C3, right? Causing pain at any one of these areas that are blacked out. All right. When we look at our posture, want to look from the side, right? Make sure your ear is over your shoulder, which is over your hip, over your knee and ankle. And for the back, you just want to make sure everything looks symmetrical, right? From ears to shoulders, right? And hips, right? Because otherwise, like, the tension will alter your joint mechanics, as well as the mechanics of the rest of your spine. So those first two bones, right? C1 and C2, they're a little bit unique as far as they have something called a myodural bridge. It's the only place in the whole body where the muscle attaches to something called the dura. And you can see on the right, the dura encases the entire brain, and then it attaches to the skull, these first two bones in the neck, and then it's loose all the way down until it gets to the sacrum, like the base, right? Then it attaches back down there too. And it acts almost like a spider web, right? It's supposed to be the last line of defense, protects the skull. But if we get stress on it in any area, right, just like a spider web, it'll start pulling and causing stress on the entire structure. This is why it is imperative that you address C1, C2, C3 when you're trying to deal with any kind of TMJ issue, because as that dura tightens, what happens to the skull? The skull doesn't move anymore. Right? The skull's supposed to move, especially with respiration. Right? It moves slightly, but it moves. Right? It's supposed to pump cerebrospinal fluid throughout the body or throughout the right central canal. And when it doesn't move because we have dural tension, right, we're going to get pressure buildup and we're going to have problems like our TMJ issues. So here's our cranial vault. If we look in yellow, here's that sphenoid, right? So this is looking from the top with the top cut off and removed. And then this is looking from the bottom. So basically, if you flipped it over, right, took this right side and just flipped it, right, then you'd get the exact left side, right? Because you can see yellow here, right? This is the underside of, this is the back side. This is the underside, this is the back side, right? Whoops. All right, so these bones, like I said, they move. And when that dura, which is attached to it, are causing too much tension, right, we get problems. And what attaches to these wings right here, this is the underside, right, that medial and lateral pterygoid. They attach right there, that wing. And you get other muscles attaching here to the temporal bone. Right? You get the ligament attaching here, right? So as they dysfunction, we're going to get stress on our TMJ. Okay, we talked again about trigger points. We already discussed that one. So with chiropractic, what do we look at? Well, first thing we got to do is restore the proper alignment, right? Get that first three bones in the neck to start getting a normal signal to the brain so we can dampen down the signal of that trigeminal nerve going right to the TMJ. After that, you want to release the dura, okay, that web-like structure that's putting too much tension on it, and then correct the cranial bones that have been misaligned from it. Right, then we're going to balance a function, which we can do at home depending on how bad it is. Right, we're going to go over that in just a minute. And then we enhance the nervous system function. Right, we look at the sacral base as well. All right, so the home protocol for releasing those muscles, right? See if there's trigger points in them or whatnot, right? You don't want any kind of sharp pain. Okay, pressure should feel like, painful, but like a good kind of pain, not like a stabbing type of pain that you're just trying to, be brave. Okay, breathe slowly. Don't never hold your breath. Okay, and if symptoms increase, stop and seek help. Okay, so this is not a fix. This is just to try and balance out some muscles, right? You always want to see a qualified professional to see exactly what's going on, but we can give some relief with some muscle work. Okay, so we're going to look at those muscles of mastication. The two biggies are our masseter and our temporalis. Here's the thing, right? That you have something called fascia, which is almost like that same network that is with the brain and spinal cord, with the myodural bridge at the meninges. It also is on the outside of the body, right? So on your temporalis muscle, it'll connect the temporalis down to the masseter muscle, right? So those two can be connected through that fascial line, all right? You see trigger points can be in the entire belly of the temporalis muscle, as well as in the masseter. You just have to kind of feel around there. You'll feel like a little nodule almost, right? And when you press on it, it should cause your symptoms to increase. If you just either cause little gentle circles, like 20, 30 seconds, or you can just cause a little bit of pressure and hold it for about 20, 30 seconds. And it should almost feel like it melts away, what the trigger point does. And then the muscle, the spindle cell resets, all right? The other biggie is the SCM, which is that neck muscle. If you turn your head to one side, oops, okay, sorry. There it is. All right, a couple slides behind you. All right, that SCM, right? If you turn your head to one side, it's that muscle that pops out. Okay, so there's usually, you just kind of pinch it. You go all the way down, right? Kind of from the sternum, just start up at your skull, and you just kind of follow that down and pinch it. And if you're feeling kind of like taut band and it causes your symptoms anywhere in that red area, you just hold it for about 30 seconds until it feels like it melts away. All right. And the suboccipitals, right, is if we had that forward head posture, these are the muscles that are right behind the base of your skull. Very important to clear these out because, again, the neurologic drive that's going to be going into your spinal cord is going to cause your TMJ to be reset, very sensitive to just the slightest touch. That's why, if you just kind of, a breeze goes by your head and all of a sudden your TMJ flares up, it's because it's set so high because of things like the suboccipitals that are in spasm. Right? So you can use a tennis ball. It's great, right? Just stick it under the base of your skull and just kind of roll around a little bit on it. Okay. If you have somebody handy, they can use their fingers back there, right, to just hold it. Right? Again, like 30 seconds will typically cause them to just kind of melt away. Upper trapezius, we put this in there because right, everyone's usually sitting way too long, and it can refer to your TMJ. You see trigger points are where the X's are, right, the top part of the shoulder, and then on the back as well. Okay, same rules apply. Okay, then the levator scap is the last one, right? It's above the scapula, right, looking from the back. Okay, these muscles this one's not necessarily on your TMJ, but because when we get something called upper cross syndrome, we get these muscles are activated, and upper cross syndrome is intimately related with TMJ problems. So, if we're thinking holistically, correct the upper cross syndrome, the pressure releases on the TMJ, and that's how we fix TMJ without touching the TMJ, right? If that makes sense. Okay, so how do we do that, right? Well, we use a neck trainer in our clinic, right? Just easy neck trainer. Once you start, after you balance the muscles, right, you lie on this, which will, again, bring that jaw back in a better position. So we're going to bring it down and forward a little bit. So we're not so much putting pressure on that posterior aspect of the joint. When we use a neck trainer, where we start low, like sometimes people start at 30 seconds, depending on how much their spine has been damaged, right? But you work your way up to like 15 minutes, right, to help bring that curve back again, right? Take pressure off of the spinal cord and allow the joint to rest. All right, then there is this pretty famous physical therapist, Dr. Okamba Bado. He put together this protocol for TMJ issues. All right, I'm going to start with the rules. Right, so it's 6 exercises. Right, hold time is 6 seconds. Right, that's why it's called 6 by 6 by 6. Right, six repetitions 6 times a day. Right, which seems like a lot, but you know, what's the alternative? You're going to suffer. Right. So it's only a couple exercises, right? You can do them pretty quickly. All right. Now, the first one is to just we're trying to teach our brain where neutral is, right? Because neutral on your jaw is your teeth are not supposed to be touching. There should be a slight gap between that. So that's what this exercise is trying to teach us, to relax our jaw muscles, because probably if we have a TMJ issue, maybe we have spasm muscles and we're grinding our teeth and we're clenching all the time, or we're causing pressure on there. So we have to learn to kind of keep that normal physiological gap in there. All right. You just place the tip of your tongue against the roof of your mouth, right? And you just kind of hold it there, right? And we progress that to opening the mouth, right? With that tip of the tongue up on that roof of the mouth. This is to start getting a normal motion in the rotation, right? Remember, the first 20, 30 millimeters opening is rotation. Then we do translation. So if we keep that tongue on the roof of the mouth while we open the mouth, we're just working on that rotation, right? To start to train that jaw muscle to bring it back into a proper motion before, you know, we engage the forward translation. Okay, then number 3 is isometric contractions, right? We're going to just start challenging the jaw in different positions and doing isometric, meaning no movement, right? Just a resistance against force, right? In various positions. And we do rhythmic stabilization, right? Again, side to side. And then a neck extension, right? We're trying to bring that head back while we hold it with our hands. All right, all designed to put us back into proper position. So our cervical retractions, we're gonna best to do these when we're by a wall, because everybody always kind of cheats. You want to try and touch your back of your head to the wall behind you, but keep your eyes directed at something in front of you, because people will start doing extensions at the neck, right? Which we don't want. We want a head retraction, right? Doing it on the floor sometimes helps first, because you can use gravity to assist you, but at least you get the motion, right, from a forward to a retracted head. And then you can start doing it when you're standing up. Right, then you can add a little weight behind here, like a TheraBand or something like that, for a little bit more resistance, so that we can start to get this head that is in extension and a forward, right, tightened muscles here and here, to fall back in a normal alignment. So the other thing with that is, with that forward head posture, we get a rounded scapula, right? The upper part of the back round, right? That's part of the that pattern, right? So we're going to try and squeeze our scapulas together, right, to bring us back into a normal posture, and then we'll add a thoracic roll, right? If you add a thoracic roll here, you're going to roll back and forth on top of it, right? Again, start light, do it for maybe 5 or 6. There should be no pain, right? It should actually feel kind of good. We just want to just roll over it, right? The more ankylosed or more kind of things have been damaged, the harder it'll be. So we definitely want to open this up, because otherwise we have problems with breathing, and our whole center of gravity gets thrown off. Okay, and then lastly would be for the lower trapezius muscles, right? And this is just getting a TheraBand, put it on a doorknob, and you're gonna almost like if you're a cheerleader, think about making a Y, right? Or right, so come in front of you and just up. We call the scapula plane, which is a 45 degrees outside of the center of your body. You take it out 45 degrees, right? And then you'll go up that way, right? Almost like you're making, like I said, a Y. That'll deal with the middle and lower part of that back to help extend, to help hold you up, so we don't have that round upper back. All right, and then you can combine all the movements, right? Tuck the chin, hold the head up strong, retract the scapula, right? Engage that middle lower trap, and keep our good posture when we're working at a desk or whatnot. All right, so here's the exercise at a glance, right? We have our tongue resting, we control the opening, we do our stabilizers, right? Our occiput, right? And then our chin tucks, and then our shoulder squeezes. Not such a bad deal. Okay, something that always pops up is our sleeping positions. All right, we could be doing a lot of damage when we sleep. If we sleep on our TMJ, it can cause issues. The thing that I find that works a lot is if you use a travel pillow, a cervical neck pillow. You just get a little safety pin for the end so you can pull it together, and then you can kind of put it right on your head, and your TMJ does not have to have that pressure on it. But if you have to sleep, right, on your back is probably a better option for you for your TMJ. All right. We definitely don't want to be sleeping on our stomach, right, because it's going to cause you to rotate your neck. And again, that upper cervical spine is just now going to be screaming on that trigeminal nerve to set it way too high, and you're going to get inflamed. Right. Side sleeping is probably be second best. Make sure there's something between your knees so that we don't get your sacrum twisted, right? Otherwise, your hips will roll forward, and that meninges, right? That dura that we talked about, that's attached down here will rotate and cause pressure and pull on the upper cervicals and the skull. Okay. You want to have some support for your spine. Now, this picture is a little misleading because this guy's head seems to be a little bit high. He's like way off of even the bed, right? I tell people though, when you're sleeping on your back, the biggest problem is people the gravity tends to pull the tongue down and choke you or make you snore or something like that. So if you are dead, you want to sleep on your back because that's the most comfortable position for you. You can lift the head of your bed up maybe 3 inches, maybe 4 inches. It's not that much that it's going to be uncomfortable, but it's enough to keep your tongue from sliding back down your throat, and you're able to actually feel comfortable with it. Okay. The other thing is we want to. We always mouth tape in my house, right? Because if your mouth is open, right, it's putting stress on your TMJ, right? If you mouth tape, you don't have to worry about that, right? You're in that natural position, right? That's the most restful position for your TMJ. The other thing that happens when you mouth tape is you're breathing through your nose. When you breathe through your nose, you increase the amount of nitrous oxide that your body's producing. Nitrous oxide is needed to keep the blood vessels supple, right? To allow them to contract, expand, and do their job, right? So it increases cardiovascular health, all right? All this stuff gets connected as soon as you go down this rabbit hole. So these are our best positions, right? Back sleeping, proper pillow, right? Neutral neck alignment, right? Support your natural curves, right? All stuff that, right? We're kind of like, duh. You should know this. All right. We went over this part, right? Either we talked about because we use tape. What kind of tape do we use? So we use a tape from like a kinesio tape, because it has to be breathable, because sometimes if you get stuffed nose, you don't want to die, right? So it has to be kind of breathable. You don't want to use something. I had a patient of mine, she was using what was it, like masking tape. I was just like, what are you doing? It's like, it works fine. Like it could tear off the skin. Again, not breathable. It's probably not recommended. You want something that you can breathe through, and you can take off relatively easily. All right. There's a whole thing we can go down on sleep, because with sleep in and of itself, it's amazing how many people have problems with sleep issues. Right, it's supposed to be as natural as breathing. Sleep's extremely important. But if you're sensitive, right, then you have to set things up a certain way, like have no, EMFs, right, from electrical, you know, handheld devices or something like that in the room. It has to be pitch black, and you have to block out all your blue lights from devices within the last 3 hours. And yeah, anyway. But if you're having trouble, send me a message. Right, all my contacts below. All right, so let's talk about inflammation. So as we said before, inflammation, acute inflammation is good, right? It's needed to burn up cellular debris. It's needed to kind of secure an injured joint. It's needed to bring in white cells if we have infection. But when it gets out of control and gets chronic, that's when we get a problem, because it'll start to degenerate, right, tissue. Right, so there's certain things we can do, right, as far as diet goes, right? We have to start to, we don't want to stop the inflammation, because, right, we never want to stop the wisdom of the body, but we want to try and control the right, the amount of inflammation that's coming, and we don't want it to be inappropriate, right? So if anybody wants, I put together a deflaming guide, kind of do's and don'ts on what to eat as far as, right, vegetables and fruits, and grass-fed beefs, and supplements and things like that. You guys are all welcome to it. Just send me a message. If, again, look at the bottom of the screen. Our socials are all the same at Form Function Chiropractic, at any of the socials that are there. Otherwise, you can use our website, and I'll be happy to send it off to any one of you guys. Supplements would include, right, omega-3s, right? Omega-3s are extremely important for anti-inflammatory. We're very high in something called omega-6 arachidonic acid, typically from our like seed oils and whatnot. So omega-3s are out of balance, right? So 2,000 to 3,000 milligrams of EPA DHA a day. There's also ALA is also an omega-3, but that's from a not an animal source. It comes from either flaxseed or black or evening primrose or something like that. But it's a very poor quality oil, because it has to be converted to either EPA DHA, and the body doesn't do that very well. So you're much better off with a fish oil or krill oil or something like that. Magnesium is going to help relax muscles, okay, to help calm down that joint. Right, then the turmeric, right, one of my favorites. Whenever you come to my clinic, you get a turmeric shot before you leave, right, to try and help control inflammation. It's also very great for being, anti microbiotic. Then we got our probiotics. Okay, we usually make sauerkraut in our house. It's very easy to make, right? I have a video on that on our YouTube channel. And then vitamin D3, usually with K2, you'll find it either 2 to 5,000 IUs a day. All right, so you can scan right there if you want the deflaming guideline. Okay, if you got a device, but you probably need a device and your computer. Otherwise, you can just shoot us a message. We're happy to send that out. Okay. So recovery time depends on, again, how long things have been out. Typically, you're looking at the first 2 weeks, get the initial relief, get the swelling down under control, start to balance muscles, right? Then week 3 to 6, right, you progress to putting the spine back in the proper position, which helps, again, bring the joint back out into a normal gait. And then we stabilize, right? And then typically the person's done by week 12 or something like that. And again, if it's been chronic or not, depending. All right. So we always seek help, right? If anything worsens, right? I personally think you should seek help, even if it doesn't worsen. But if things are worsening, right, it means your body is not healing, right? And the longer you wait, right, the worse it is for your health, worse it is for your wallet, worse it is for everything involved. Okay. If you're trying some of these things we do, and after 2 weeks, we don't see any kind of improvement, right? Again, seek help. Okay. There's any new neurological symptoms like numbness, severe headaches, stuff like that, right? Seek help. And if there's any difficulty or change in the way your body now moves and you can't open your mouth or sudden lockjaw, something like that, right, discontinue and seek help. All right. So hopefully you guys found some value out of that. All right. If you're suffering from any kind of TMJ issue, you can call my clinic. Right. We will do a special, anybody that's coming from this webinar, right? All those, the neck trainers and the thoracic rolls, and we have a whole kit we'll include with you if you decide to start care with us. All right. Additionally, we have a Landers giveaway. How are we giving that away? I don't even know.
Membership for 3.
Yeah, but who we giving it to?
From all the participants.
All right, so we're gonna give that away now or later. Why are we giving it away?
Tomorrow.
We're gonna give that away tomorrow. Landers.
You raffle all the participants.
Yeah. So if you participate today, we will raffle it off. Lovely Landers membership. Membership has its privileges. All right. So good luck to all you for that. Our next webinar is going to be I don't know, the last Wednesday of the month. Of course, as always, we're going to do scoliosis. So if you know somebody who has scoliosis, that's going to be a good one. Always very popular. All right. So tune in for that one. All right. Don't forget, like and subscribe. All right. Follow us because we are always trying to put some information out there to help everybody live healthier, happier lives. Okay. Thank you guys so much. And we'll see you at the next one. Take care.